Sir, am I audible and visible?
Yes, yes. Yes, yes.
Okay. Good morning. Ramesh, 37-year-old male, presented to ED with alleged of RTA bike versus bike on 4th of April 2021, complaining of pain over lower chest and injuries over face. On initial primary assessment, airway intact, patient talking, no C-spine tenderness, breathing but respiratory rate was 20 per minute, saturation was 98%, room air. On inspection of chest, there were no bruises or contusion. There was a tenderness of right lower chest, no bony crepitus or subcutaneous emphysema. Air entry was bilaterally equal. Circulatory part, pulse rate was 58 per minute, BP was 120 per 70 millimeters of mercury. Heart sounds S1 and S2 were normally heard. Periphery is calm. Peripheral pulses were palpable. On per abdomen examination, there was tenderness over right hypochondrium. And on fast examination, on right hypochondrium was positive, free fluid was present, no free fluid in the subsequent left hypochondrium and pelvis. On a first examination, there was no pneumothorax. Only in first was positive on right hypochondrium and thin rim of free fluid present between kidney and liver. On chest X-ray, there was there was no obvious rib fracture or there was no hemo or pneumothorax. On disability part, E4 V5 GCS was full, E4 V5 M6. Pupils are equally and reacting to light bilaterally. The patient was moving all four limbs. On exposure part, abrasion was present over right side of face, multiple abrasions over right forearm and wrist. And a sample history, signs and symptoms, lead history of RTA bike versus bike, complaining of pain over right lower chest and upper abdomen, no complaining of breathing difficulty, sustained injury to face, and abrasions over cheek and wound over lips. No history of loss of consciousness, vomiting, seizure of ear and nose bleed, no history of altered sensorium or headache. And the allergic history, no documented allergy to any drugs. On medication is currently taking no medications. Past history, there was no comorbidities. Last meet 9 hours back, and snacks read. On events leading, a list of RTA bike versus bike at 5 p.m. on 4th of April at Kasaragod, taken to nearby hospital, lacerated wound over lip, sutured, referred to Kannur MIMS, evaluated from Kannur MIMS. From there, CT head to pelvis were taken and incidentally detected to have COVID-19 and referred to here. And head to foot examination on head, first scalp, there were no laceration or contusion. On eyes, there is no periorbital edema, no subconjunctival hemorrhage. Vision was bilaterally normal. Nose orifice like nose and ears normal. Abrasion was present over right cheek and tenderness present over right maxilla. And lacerated wound of size 3 into 1 centimeter present over upper lip, which was sutured from outside. An oral cavity, the right upper incisor fracture was present. No neurological deficit. On neck, there is no C-spine tenderness, no subcutaneous emphysema, no distended neck veins, trachea was central. Chest, there were no bruises or contusion, tenderness present over right lower chest, no bony crepitus or subcutaneous emphysema, air entry bilaterally equal. And heart sounds S1 and S2 normally heard. Per abdomen, no abrasion or bruises, soft on palpation, tenderness were present on right hypochondrium, no guarding or rigidity, no organomegaly, bowel sounds were heard. Perineum, there is were no blood in meatus, no perineal ecchymosis, pelvic compression test is negative. Then extremities, right upper limb, abrasion present over right forearm and wrist. There is no contusion, deformities, or abnormal movements. On left upper limb and bilateral lower limbs, there were no signs of any injuries, no abrasions, no contusion, deformities, or abnormal movements. Then on lower broad, there were no visible injuries and no spine tenderness. Per rectum examination with normal limits. Then diagnosis is like RTA, free fluid in the abdomen, soft tissue injury, right upper incisor fracture, and COVID-19. And investigation were sent urgent CBC, serum creatinine, electrolytes, LFT, amylase, lipase, and serology. On HB, it was found to have 15.2. Outside HB was 16. On CCT, abdomen taken from outside shows multiple linear laceration in segment 5 and 6 of liver, largest measuring 5.3 centimeter, grade 3, and no obvious vascular injury. On pelvis, there was no body injuries, urinary bladder and prostate were normal. CT head, CT C-spine, CT thorax taken from outside are normal. Then patient kept on NPO, analgesics, antibiotics given, gastrosurgery consultation given. They opted for conservative management, plan for admission in MDICU. Thank you.
Okay. Okay, Shaim. So we have, what is your case now? It is a liver laceration.
Laceration of liver.
Laceration of the liver. Okay. So, okay. ഈ ഫോമാറ്റ് എവിടുന്ന കിട്ടിയ ATLS ഫോമാറ്റ് അല്ലേ?
അതെ.
ഓക്കെ. ഈ ATLS ഒരു ഇനീഷ്യൽ ഒരു 10 സെക്കൻഡ് അസസ്മെന്റ് ഇല്ലേ? അത് കേട്ടിട്ടുണ്ടോ?
അത് ചില പ്രസന്റേഷനിൽ കണ്ടിട്ടുണ്ട്.
But basically, our initial 10 second assessment, that is when you're just seeing the patient, you're eyeballing the patient. So, explain before going to ABCD, we have to say that the patient has come. There is something called MIST, MIST. Usually, it's a mnemonic for a pre-hospital scenario. The ambulance, the EMS staff will come and say that I have done certain things. This is the patient. MIST, the mechanism of injury, mechanism of the RTA or whatever the mechanism of the accident. I is injuries sustained, S is signs and symptoms, and T is treatment given. So, this parnitayirikkum nammal EMS aarkare ideally should come and transfer the patient for your care. But when you get such a patient, you are first going to see an initial 10 second assessment. That is just the patient conscious aano, patient airway okay aano, tachypneic aano, along peripheries cool and warm aano, distal pulses okay undo. So adana 10 second assessment. So just try saying that 10 second assessment before going for ABCD. Okay, so now airway breathing is okay, circulation is also okay. So there's nothing wrong with ABCD, right?
Yes.
Right. Okay.
So ABCD, nothing wrong.
There's nothing wrong with ABCD. Okay.
Patient was stable.
Patient was stable. So what is the patient's complaint now?
Patient right lower chest pain.
Right lower chest pain. Okay, so what are you thinking of when a patient after an RTA comes with right lower chest pain? What all problems can he have?
First of all, any rib fractures.
Rib fractures, okay.
Soft tissue injury might be the condition.
Okay, before that question, let me just ask you, what are the life-threatening emergencies according to the new ATLS? Life-threatening emergencies.
Tension pneumothorax.
Airway.
Airways. any threatened airway obstruction.
Okay, airway obstruction. Okay.
Maybe then on breathing part, tension pneumothorax and massive pneumothorax, and cardiac tamponade.
Cardiac tamponade. Okay. Then traumatic cardiac arrest. ഒന്നും കൂടെ in airway something else. Somebody can help him.
So tracheobronchial tree injury.
Yes, tracheobronchial airway injury. So before flail chest and all that was there in the ATLS guideline. അതൊക്കെ മാറ്റിയിട്ട് ഇപ്പൊ tracheobronchial trees ആണ്, tracheobronchial injuries ആണ്. So airway, breathing, and circulation. Okay. So when a patient is presented with your right-sided lower chest pain, you're suspecting any life-threatening injuries according to your ABCD? No.
ABCD, no.
No. Okay. Sure. So now, what all injuries are you suspecting? In your secondary survey, is there any positive findings?
There was also tenderness in the per abdomen, right hypochondria.
Right hypochondria. Okay. Tenderness matra.
Tenderness matra.
And there is no ecchymosis, or there is no abrasion.
No external injuries. No external injuries.
No external injuries. Okay. So, so how is this mechanism again?
Mechanism, bike versus bike, and direct bike versus bike, direct head-on collision, but a low velocity.
So it's a low velocity. Okay. So you have to, when you present an ATLS case, you also have to give slight importance to the mechanism part. Don't just say it's an RTA bike versus bike, because if it is an RTA, whether the patient, if a car or bike, car if the patient is having a rollover, what all mechanisms can happen? Ejection, rollover, all these things can happen in a car. Similarly, was the speed fast or the speed very low? So mechanism is very important when you discuss a case, especially with abdominal injuries. Okay, whether it is a high velocity, low velocity, whether the car toppled over, whether there is a whether the patient was wearing a seat belt if the patient was in the car, airbag ഒക്കെ പൊട്ടിയിരുന്നോ, ഡ്രൈവർ ആണോ, ഡ്രൈവർ അല്ലേ, ഇതൊക്കെയാണ് മെക്കാനിസം ഇമ്പോർട്ടൻറ്റ്. Okay. So again, so what injuries are you suspecting again? You told me one is lower chest, rib fractures.
On secondary survey, there was per abdomen right hypochondrial tenderness. So there can be intra-abdominal injuries also.
Okay, intra-abdominal injuries. Any other injuries?
Other injuries are on abrasions over face and.
Any other injuries with this right lower chest pain? What are the injuries that you only if you think you can you would be able to find out? Okay. So what all you've thought about the rib? Okay, rib fractures. Then you've thought about the lung. Probably a small. You're suspecting a hemo and all that. Not a tension pneumo. Probably a hemo pneumo. Okay. Anyway, but air entry is all okay. ABCD. There are no issues. Then what?
Then liver injury.
Okay, intra-abdominal injury, liver injury. Okay, liver injury. Then
liver. Kidney injury.
Okay, kidney injury. Something that we tend to overlook. Sami?
So diaphragm injury.
Sorry?
Diaphragm.
Diaphragm, correct. Diaphragmatic injuries are also something that usually there is a chance that we overlook it. Okay, so especially since you're saying the patient is having right lower chest pain, you have to think of diaphragmatic also in connection to abdomen and this. Okay, so coming just okay, since we talked about diaphragm, which side is more common in diaphragmatic injury, right side or left side? Usually left. Why left?
കുറച്ച് lower position.
Sami?
Liver, right side liver.
Yeah, correct. So the liver is there. So the liver will acts like a, it'll absorb all that kinetic energy. That whole force will be absorbed by the liver. So that is why usually there won't be right-sided. Can't say no. They won't be. It is less common than the left-sided MCD. Okay. So that is that. What else? Okay. So you've done a fast exam, right, for this patient?
Yes.
Okay. So you found a fluid in the Morrison's pouch. So how much fluid has to be present in your abdomen for a positive fast, or for the, that the Morrison's pouch is the first place the fluid is going to come, right? Usually the first place that the blood is going to come or sweep in. So how much of blood has to be in the peritoneum for a fast to be positive? Anybody can answer.
So 50 ml.
Oh, no. Oh, not 50 ml. No. Sami 50 ആണോ പറഞ്ഞത്? 50? അല്ല 50 അല്ല. ബിന്ദ്യ ഒരു guess. Correct, very good. 250 ml. 250 ml of blood needs to come out of from wherever it's coming, so that you can have blood in your Morrison's pouch. So just because you see a fast, we are not supposed to. Sometimes we have to. We are not supposed to do the practice that we usually do, just doing fast only once. As long as the patient is in the ED, we have to repeatedly do a fast, because the one fast might not be, the blood might just slowly start sweeping. Okay, so we have to do a repeat fast always, as usually in intervals of half an hour to 1 hour. Okay, that is the usual dictum. Okay, so that is okay. So I fast, that's the only thing positive in fast, no?
Yes.
Okay, so this patient is hemodynamically stable. You have a fast positive. What is your next line of management?
If to look, what's the look for any active bleeding, patient is stable, then we can send urgent HB.
ഇങ്ങനത്തെ ഈ ആൻസേഴ്സ് പറയുമ്പോൾ നമ്മൾ ഇവിടെ പ്രാക്ടീസ് ചെയ്യുന്നല്ല, നമ്മൾ ATLS പറയുന്ന എന്താണ് ആൻസർ?
Patient is stable patient. So we can look for, we can send for radiological investigations.
Okay, you can send for radiological investigations. So a stable patient with a fast positive, you're going to send them to CT or no? That's the question.
Yes. CT. Yes.
Okay, you can send. Okay. At the same time, if the patient was unstable, no doubt the patient has to go to the OT for laparotomy. So always when you the whole thing depends on whether the patient is stable or not stable. So on that note, what are the clinical features that you're going to get in a patient who's come with a trauma to the abdomen? What are the clinical, or how reliable are the clinical features when a patient comes to you with abdominal trauma? Sami?
Sir?
What I asked is,
sir.
This is your Auscultation. I'm telling you, clinically examine the abdomen of the patient who's come to you with trauma.
Okay.
What all are you? Just tell me what all are you going to look for.
abdominal examination.
Yeah, abdominal examination. A, B, C, D is all over. Okay.
In abdomen per se, first we will inspect whether there is any visible
Okay.
abrasion,
Visible
any
abrasion.
laceration.
Okay.
Like
Okay.
inspection wise, any deformity, any injuries there.
Okay. Okay.
Then palpation will
Okay.
palpate all
If
the
so
spots.
we have a patient who has been in who has been in a car crash. This patient was in the side seat, not the driver's seat, the side seat. Okay. The patient was in a high velocity injury and sudden resulted in collided with some stationary objects, resulting in sudden decelerative force. So what can you see on the abdomen in such a patient if the patient was wearing a seat belt?
Seatbelt sign can be
Okay.
seen. The
Okay.
ecchymosis can be seen.
Okay. Okay. So always look for a seatbelt sign. So why the seatbelt sign is important is because, you know why? If the seatbelt sign is seen above, if the seatbelt is seen above the anterior superior iliac spine, if it is above that, the chance of injuries that the patient could have will be a little more. Okay. So always see for this whether if there is a seatbelt sign, if it is crossing above the anterior superior iliac spine, if it is above the spine. If that is the case, there is a high chance for internal injuries. So we'll come back to the rest of the examination and all that. On this note, if you see a seatbelt sign in a patient, what else do you have to think of? Obviously, intra-abdominal injuries. Something else?
Vessel injury, aortic injury.
Vessel injury, correct. Vessel injury, then what? Especially in children.
Kivora,
Sevora may or may not be there, but imagine you have somebody who's decelerated and has gone and stopped. The car has stopped, and you are suspecting a seatbelt injury. So you told me one is seatbelt, അതായത് abdominal wall ecchymosis ഉണ്ടാവും. പിന്നെ ഉള്ളിൽ intra-abdominal ആയിട്ട് പ്രശ്നങ്ങൾ ഉണ്ടാവും. Either it will be a hollow viscous or it will be a vascular. Okay. Then go behind that. What is there behind?
spinal injury.
Spinal injury. So there is a particular fracture that is associated with seatbelt injuries. What is a chance fracture? What is and the chance? What is a chance fracture? What is it?
Flexion, due to flexion.
Correct. Go ahead. Because of flexion of the whole back. Basically, because of the flexion of the whole back, the transverse there'll be a transverse fracture of the vertebra, thoracic and lumbar vertebra. Okay, that is called a chance fracture. So whenever you see a seatbelt sign, always look for chance fractures in the back, in the abdomen. Look for hollow viscous injuries. Look for vascular injuries. And also in the abdominal wall, you're going to, what can happen? Sometimes you can even have a rectus sheath hematoma or an abdominal wall hematoma. So all these things could be there in a high mechanism injury. Okay. So coming back to clinical features, one, you've said inspection. On palpation, what's going to happen? What all are you going to look for? Sami?
Palpation. We look for tenderness. We look for any guarding, any rigidity.
Okay. Tenderness, rebound tenderness. Okay. Tenderness and rebound tenderness, guarding rigidity. Okay. Then distension, as usual.
Auscultation. We go for auscultation.
Auscultation. So what all are you going to look for in auscultation?
Whether there is any bowel sounds.
Okay. So bowel sounds is reduced. when do you have, after trauma, if the bowel sounds are reduced, what are the causes? What can it be?
Any hollow viscous injury?
It's all straightforward. Hollow viscous injury causing all your contents, all your bowel contents will come out and cause chemical peritonitis. So that is something that is going to cause any irritation of the peritoneum and all that is going to cause a bowel sounds to be decreased. Okay. So another thing that you have to look is whether you can hear bowel sounds in your chest. Okay, above. Okay, so always when you auscultate, see whether you are having bowel sounds above the chest, because sometimes when you have a diaphragmatic rupture, some of the bowel content can go up. So whenever you're saying examination of the abdomen in a case of trauma, inspection, palpation, and auscultation. Okay. One more thing that I want to say is when you have a patient with altered sensorium coming to your ED after a trauma, are you confident enough to say that, okay, there is not going to be any abdominal injury for a patient? By guidelines, what does ATLS tell us? If a patient has come with polytrauma, you're going to do your initial fast. Once you do your initial fast, you have to do your repeat fast, right? To see whether there is, frequently you have to do your fast. But if the patient is coming altered sensorium, you've done your fast, the fast is negative. What are you completely sure that the patient is not going to have abdominal injury?
No, sir.
Yes, Ami?
No.
So keep your threshold for a CT abdomen there low. See, ATLS has told, keep a threshold very low. I'm not saying it is an indication. Keep a very low threshold. Now, this is just a practical point. Okay, keep a low threshold to take a CT abdomen in a patient who is coming with altered sensorium with a fast negative, and the patient is in shock. Now, why are we go ahead with a CT abdomen? And so, coming back to I'll reframe the question in another way. What are the drawbacks of an ultrasound fast?
You cannot get retroperitoneal bleed.
Exactly. Retroperitoneal diaphragm, all these things will not, hollow viscous, all these things are not available in the fast. So to look at all that, we have to take I'm not saying we have to, we probably could take a CT. Okay. Now, you take a chest X-ray in this patient. The patient has come with what all are you going to look in your chest X-ray in a patient with abdominal trauma? I'll frame the question like that. Okay. What all are you going to look in the chest X-ray when a patient has come in with a blunt abdominal trauma? Somebody.
Pneumothorax.
Okay. Pneumothorax.
Bowel in the chest.
Bowel in the chest.
Air fluid levels.
Correct. Cardiac. And also one. Cardiac injury. What will you get on the X-ray in a cardiac injury? Unless the patient is having a traumatic pericardial effusion, which is causing a globular heart to, be there. Yes. Okay. One more thing. One more thing. Diaphragmatic parnu. Sami parnu. Diaphragmatic. One more thing. Air under the diaphragm. Air under the diaphragm. Okay. Something when you have that might be a subtle indicator. That might be the only indicator sometimes. So the take-home message that I want to say is clinically, if you say that I've touched my patient, there is no signs, there are no abdominal signs, so I didn't do a fast. That is a wrong thing to do. Whenever your abdominal examination, your clinical examination in a setting of blunt abdominal trauma is very unreliable. You cannot rely on them. So you have to do a fast. Okay. Even though they say you do sometimes they say you do a fast only if you have hypotension. When you have hypotension, obviously you have to do a fast along with other things. But because your abdominal examination is very unreliable, you are warranted to do a fast in a blunt abdominal trauma setting. Okay. All right. So that is that. Now, what are the indications for laparotomy or urgent laparotomy in a case of blunt abdominal trauma? Anybody? Urgent
Hemodynamic
laparotomy.
instability.
Hemodynamic instability with
free fluid
Stay fast.
with fast positive. Okay. Patient goes to the OT. If the patient is hemodynamically stable, but has features of peritonitis, where will the patient go?
OT.
OT. Okay. So patient is hemodynamically stable. Either patient is BP 170, but obviously patient is going to have features of peritonitis, the abdominal distension, tenderness, rebound tenderness. All this is there. Still, the patient will go to the OT. Again, if the patient, what are the other indications?
Penetrating abdominal injuries.
Penetrating, correct. So blunt abdominal trauma in patient is unstable. Penetrating abdominal trauma, patient is unstable. Okay, then.
Evisceration.
Okay, evisceration. Then. Again, we air under diaphragm ഉണ്ടെങ്കിലോ?
Perforation.
Perforation. Again, diaphragmatic rupture again, and GI bleeding. If you happen to put your orogastric tube or NG tube or something, and if you see continuous blood coming out, when you have a hollow viscous rupture, when you have such things, you have to take the patient for urgent laparotomy. The first two we will know. The other two is what we have to look for. For that, we have to look for the X-rays, look for pneumoperitoneum, look for diaphragmatic rupture, look for GI bleeding. Okay, that is you take them up for urgent laparotomy. Okay, now just what else can we discuss about? So what is DPL and DPA and all that?
Diagnostic peritoneal lavage.
Diagnostic peritoneal lavage.
And what is DPA? DPA and the diagnostic peritoneal aspiration. Aspiration. Okay. So what is the difference between DPL and DPA? And why is DPL and DPA and all that not done nowadays?
We have much easier options.
Okay. Then
Higher risk of infections.
Okay. But the sensitivity is really high when you do a DPL. But still, like you say, we don't do it nowadays. Okay, because it is very invasive, and just by saying okay, there is blood in the abdomen, we need to find out where the blood is coming from, right? We have to find the source of the bleeding. Just by saying okay, I'm putting a needle and pulling out some blood, I can prove it with the ultrasound or a CT scan. So that is why the role of DPL is usually going out. So when someone asks you about DPL and DPA, number one, if the patient is having abdominal distension, you put your syringe into the peritoneal cavity. If you can draw around 10 ml of free blood or any other contents, whether any GI contents, that is a DPL positive. DPA positive. DPL positive is what? You're infusing around 1 liter of warm saline into the peritoneum, and then you're going to take out the aspirate, and you're going to see under the microscope whether there is any RBC, WBC, and all that. So there are cutoffs for that. I don't remember exactly. So a positive DPL again is an indication for a laparotomy. All right. Okay. So okay. Now what is REBOA? REBOA.
Retrograde endovascular balloon occlusion
Of the Aorta. Why do you do that?
When there is a significant injury, vessel injury, causing life-threatening bleeding.
Basically, you're going to okay. There is some significant. Okay, fine. There is some GI. Say if somewhere the patient is bleeding from the abdomen. Okay. So what do you do? And the physiology and basically, and
We go in through the femoral,
go to the aorta, inflate the balloon, and block the aorta. It is just like when you do in a traumatic. Then when the traumatic cardiac arrest comes, once you put that incision and all that, and you enter, the first thing is to either you clamp the abdominal aorta or you clamp the thoracic. I mean, you repair the thoracic aorta. So our clamp ആണ് നമ്മൾ in non-invasive ആയിട്ട് ചെയ്യുന്നത്. Okay. From you're going to block the aorta. Now, if you have a pregnant patient come to you with abdominal trauma, what extra precautions you will keep in mind when dealing with that patient?
In trauma or in traumatic arrest?
Trauma. When a pregnant patient has now come with an abdominal trauma.
Patient should be tilted to
left lateral position. Okay, then. First of all, what are the problems that can happen in a pregnant lady coming with trauma?
Pregnant lady, hypotension can be
delayed. Okay, so vascular resistance is low, so there will be hypotension. Fine. Then okay. How is volume status and will they have a larger volume?
Larger volume, but hemodilution.
With hemodilution. So hypervolemia. Hypervolemia will be. So therefore, when a patient comes with abdominal trauma, again, case to case basis, see that the patient's in the left lateral position. And if the child has crossed a period of viability, then you have to, that is around 24 weeks, then you have to continuously monitor, do fetal monitoring there. Okay. So now imagine it's a very bad trauma. In a very bad trauma, you have a positive fast, you've taken the patient to the OT. Okay. Is there any other indication for emergency exploration in a pregnant patient who's come with blunt abdominal trauma? Is there any indication for laparotomy apart from whatever we've just said in a pregnant patient? Very good. Uterine rupture and placental abruption. These are the two conditions. So always these two things keep in mind. The rest definitely we are practicing day to day. But extra just note that we have to if the child has crossed period of viability, we have to monitor CTG vechittu, we have to monitor the child's waves. Also, if there is any uterine rupture or placental abruption, you have to take them up for immediate exploration. Okay. All right. So that is that. I think any other positive findings in this case? Only liver laceration is there. Only liver laceration is there. Okay. Okay. What is did you catheterize this patient?
Patient was catheterized from outside.
Patient was catheterized. So how was the urine?
Urine was clear.
So there is no injury to the kidney, ureter, bladder. Nothing.
No injury to the kidney, ureter, bladder. Which on CCT abdomen is mentioned.
Okay. Any other questions relating to this presentation? Any question? Is there a role for radioembolization in abdominal trauma?
Yes.
Yeah. Which? When? Huh? Okay, so basically we've taken the chest X-ray and we've taken a pelvic X-ray. So if someone sees a pelvic brim fracture, okay, or fracture of the pelvic ring, always you have to suspect that there might be a close proximity abdominal injury. It can be either the rectum or it can be the bladder. Depends on case-to-case basis. So where do you do a radioembolization?
A fracture. Patient is in shock,
in hemorrhagic shock. Okay. Or may patient. Okay, patient may be stable or unstable, but if you to do radioembolization, it is always a call to be taken by the treating surgeon. It is always a chance between pre-peritoneal packing or whether you have to do a external fix. But if the patient is definitely unstable, go ahead with the radioembolization. But what does ATLS say? If the patient is unstable, you have to go to the OT directly. Okay. All right. So any other doubts with anything that we have to cover again today for this class? We've talked about mechanism, we've talked about clinical features. Labs. Okay. So what are the, when a patient comes with blunt abdominal trauma, what are the particular things you have to look at? Okay, one is HB. Next, after HB,
LFT.
Okay, what's going to happen to LFT?
If there can be a blockage of ducts or something.
So
ALP
what will the patient have?
ALP can be elevated.
Okay. Patient can have transaminitis. Okay, mild in the hundreds range. Okay. Then
lactates. We have to look lactates.
Lactates, very good. So what is the new ATLS tell? Before saying lactates, you have to look at the hematocrit. So always HB and hematocrit comes together. Why is hematocrit important when we deal with a trauma patient?
Hemodilution.
Hemodilution, okay. Or hemoconcentration. Why is hematocrit important? Now see, it's a usual scenario that happens. We fluid resuscitate a patient whose initial HB is 13. Next reading, the HB might fall to 12. The next reading, the HB might fall to 11. Why is that? So you
overcorrecting with the fluid only.
So first of all, we have to first rule out there is no massive hemorrhage, and if we have to look at from the time of the injury to the to when the lab value was done. That is a different picture. But the usual scenario is we use over judicious use of fluids will cause hemodilution, and your hematocrit will
decrease.
Okay. Hematocrit will hematocrit will fall down. Less than how much?
42.
Okay, so around 30 to 40. They usual cutoffs are around 30. Now in our San Francisco rule, it is what? In syncope, San Francisco rule, what is hematocrit cutoff?
30.
No?
30.
30. Okay, 30. Now, also other gynae we have to look for lactates and also base anion gap. Sorry, base excess. So yeah, on that note, since we're talking about base excess, Shavin, can you classify hemorrhage according to ATLS? Hemorrhage.
Class 1, 2, 3, 4.
Okay. What is class 2?
Class 2 is the blood loss between 15 to 30%.
Okay. Where does hypotension start?
Hypotension only start on class 3.
Very good. What is the base excess? The base excess value, the cutoffs in all the, because that's something new that came into the ATLS. No. So base excess, how you classifying according to base excess?
മൊത്തം 0 to 10 ആണ് whole class. 1
Correct.
0 to 2 class 1.
Okay. ഞാനും നോക്കണം. സമി ഒന്ന് നോക്കണം. Ivan.
0 to -2 ആണ് sir class 1.
Minus 0 to -2, -2 to -6. And minus, so -6. Always remember -6. -6 and upwards, you should be very careful. Okay. So that is the labs. We've discussed imaging, always fast and always repeat fast. Okay. CT as and when indicated. Chest X-ray, pelvic X-ray, we've said. We've discussed the indications for urgent laparotomy. In case the patient has died, is there a role for? What is the indication for emergency thoracotomy? Since we just discussed, right?
Hemothorax.
Massive hemothorax. Okay.
More than 1,500 ml.
Okay.
Coming out, or 200 ml per hour for 3 hours.
Okay. 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 Then Sami?
Vessel injury.
Emergency thoracotomy ആണ് sir ചോദിച്ചത്?
Emergency ED thoracotomy. Indications for ED thoracotomy.
Witnessed absent penetrating injury.
Arrest, yeah. Less than how many minutes?
10
Cardiac
minutes.
arrest happens less than 10 minutes.
10 minutes.
Okay.
10 minutes.
10 minutes. Okay. All right. So these are all just for for what purpose?
10 or 15.
I think it is. ഞാനും sure അല്ല. I'll just find out. 10 അല്ലേ?
Not very sure, sir.
Okay, we'll see. I'll also just look and let you know. So I think that is all regarding this case, because it's a very stable case. Next time, Shaheen present something where we can, actually ask you from A to Z. Okay,
sir.
Yeah. Anything else to be discussed? Venu sir, anything else to be discussed, sir?
ഒന്നുമില്ല. ഞാൻ അതിന്റെ ആദ്യത്തെ കുറച്ച് ഭാഗം കേട്ടിട്ടുണ്ടായിരുന്നില്ല, പക്ഷെ കുഴപ്പമില്ല. ഓക്കെ, ഫൈൻ. വേറെ ആഡ് ചെയ്യാനില്ല. റോമ ഞാൻ കേട്ടു, ബാക്കിയെല്ലാം കവർ ചെയ്തിട്ടുണ്ട്.
Okay, sir. Okay, sir. Thank you. അപ്പം